Good afternoon, everyone. It's Dr. V.
And Dr. Horn, welcome to our webinar on surgical site infections.
We wanted to cover this because there were some requests for this topic, and there are some new updates. So we just thought we'll go over it, keep it a discussion. Our pharmacist, ID pharmacist Sumaya Asad might join as well. So we will, if there's any questions, she could also chime in. But we wanted to start talking about surgical site infection. We'll also touch base with some of the newer updates that were done in 2022 with the SHEA guidelines. They updated some newer recommendation, and we'll share some data and have a discussion. So background, Dr. Horn, I see a lot of surgical site infections sometimes, different types of surgery. Either it's like knee or joint replacement, intra-abdominal, C-section. Do you tend to see these infections as well post-surgery?
Yes, we see them, and then sometimes it's pretty clear, if there's pus or if there's a lot of redness and pain, and pain not just from the surgical procedure, but sometimes it's pretty obvious. Sometimes it's not very obvious, and sometimes people kind of look at it and they say, "Oh, there's some redness, but it's not too bad." And sometimes it can be more difficult than others. Whether it's superficial on the skin or whether it's deep. And if there's a deeper fluid collection, is that infection or is it just some inflammation there? So sometimes it's easier to tell, and sometimes it's not so easy.
Yeah, and our infection prevention is they have a hardest job when it comes to surgical site infection, because you have to follow these infections depending on the site for up to 90 days. So they have to keep an eye on these patients when they come back to the system. Do they have signs of infection? So it's very tricky, but we'll talk about some of the ways to prevent them and tools. Just looking at the data in 2015, there were over 100,000 cases. And 2022, NHSN report says they're still increasing about 4% of the cases of SSIs, surgical site infections. And our SIR rate has kind of went up in surgical site infections too. In our particular state, when we look at surgical site infections, some of the struggles we have had is with hysterectomies, C-section sites, as well as colorectal surgical site infections. So there are some tools, we'll talk about them as well.
So infection control practices have been improved, as we go along. This is, a really good area for, continuing improvements in bundles. And so improved operating room ventilation, sterilization methods, barriers, surgical technique, antimicrobial prophylaxis. So there are kind of a lot of things all like taking part and could make a difference here. So it's not just one thing, it's really a combination of things and making sure everything is kind of, as it should be.
And, you call it like the bundle approach, just like we have it for central line insertion. Surgical site infection also has a bundle that's very important to follow. With surgical site infections, you can have significant morbidity, prolonged hospitalization, mortality. So, and of all the hospital-acquired infections that they track, like CODIs, CLABSIs, MRSA, C. diff, SSIs are about 20% of all the hospital-acquired infections. So it takes up 1/5 of all the infections in US. Cost is significant, and per admission, if you have an SSI, it can cost up to $20,000 per admission. So not only patient harm, but then it also puts a lot of cost burden as well.
So, you do, Dr. V, you do a lot more of these than I do. I think, if some of the hospitals that we work with or the listeners, if they have a concern over higher rates than they should, where should they start? Should they kind of go through, the bundles and go through and make sure everything is being done?
Yeah, at the end, we're going to share some resources, what bundles to use, but I think definitely for to assess surgical site infection, it's really important to have a multidisciplinary team in your healthcare facility. That should include, definitely led by the infection prevention leader, their surgery leader, and and it needs to be a multidisciplinary approach. Pharmacy, if you have infectious disease. So it needs to be a multidisciplinary approach. And some of the things where it's successful is that reviewing these cases right after they happen to look at what gap, what opportunity did you have? And if you missed an opportunity, how can you do better, right? So we will give you some links, AHRQ, NHSN, SHADE, they all have lots of tools. But I think the key is not only doing the tools, but working as a team and looking at these cases is going to be really important so that you look at opportunities, gap analysis.
So risk factors for surgical site infection. So surgery that lasts more than 2 hours, elderly adults, overweight, smoking, if the patient has a history of cancer, immunosuppression, diabetes, emergency surgery. So if it happens emergently, and then abdominal surgeries. So these are just some of the risk factors. I think, there are a whole host of risk factors.
I think this is really good, quick, high risk factors. One of the things that it's really important if you're having elective surgery for your patients, pre-op evaluation, prior to surgery is really important where you optimize the patient's health and their condition. And one of the most important things during that time to pay attention is your hemoglobin A1C. For your diabetic patients, making sure looking at their hemoglobin A1C and talking about, can you get that down? How can you help them so they get optimized for surgical time? So I don't do a lot of the work, but in our health system, we do have folks that, see their patients when they have higher, elevated hemoglobin A1C and help the patient get under better control. I know there's a lot of smoking cessation counseling given prior to surgery as well. So these are appropriate for elective surgery when you have that opportunity to help the patient. And here is a nice diagram that we took from AHRQ, where they kind of define superficial infection, deep infection, and organ space infection. So superficial infection, purulent drainage from the wound, positive wound culture, pain, redness, swelling diagnosed by surgeon. Purulent, deep is purulent from the deep aspect of the dehiscence of the wound. You could see abscess on a CT scan. Organ space infection of the surgical cavity abdomen. So different levels of surgical site infections. One thing to remember that we have seen opportunity is that present on admission. So sometimes things might get called as surgical site infection, but it wasn't, it was actually present on admission. So this is why it's really important when you're looking through a case to involve all the party to do a debrief on that case, because sometimes you can actually go addend a note and such because you found out it was present on admission, but it wasn't documented properly. Or in the future, that we need these documentation. So going forward, we'll make sure to do that. So it's really important that we have had some opportunity where present on admission was not documented well. So there's another opportunity for that.
And I think this is good, a good way of defining it, because these will also have different management and treatment. So superficial, I think, antibiotics, like even PO antibiotics might be okay if it's like a superficial strep infection, but deep, if there is a fluid collection or an abscess, generally that needs to be IND'd or, opened up. So if it's not open, it's not draining, it would need to be drained. And then organ space, here it has a picture of the abdomen, but if they did a like infection on a bone, then does it have a bone infection, or is there hardware in the bone? The management also comes into play when it comes when you're looking at treatment for these. And then here's another picture of it. So it has skin and subcutaneous, so superficial. So these are incisional.
And this is kind of the NHSN definition too. So that's how they look at the surgical site infection. But yeah, I really like this diagram, kind of, superficial is skin and sub-Q. They say deep incision is deep soft tissue, muscle and fascia. And then of course, organ space when you're looking at I think that's the colon or
And
small bowel.
and then the deep ones or organ space, usually if there's an imaging that's done like a CT scan, then there's a question, is that like a post-op seroma? Is that just fluid, or is that an actual infection? Any tips on figuring that out?
Clinical is different than NHSN definition, so those things are hard, but clinical,
Yeah.
I put
Yeah.
both hat on and,
Yeah.
usually I can't remember all the definitions and all the little things infection prevention experts look through. But yes, for us, it's easy, if
Yeah.
there's, you open it up, there's abscess or on CT scan. Just wanted to kind of highlight this study that was done in, I believe it was Johns Hopkins, where they looked at superficial, deep, and organ space infection and initial and readmission. And what they ended up seeing in these cases was that when you got deep organ space, deep space infection, your length of stay and readmission and mortality went up. So surgical site, as you see, readmission rates were almost 18% for these colorectal cases when they get surgical site infection. So earlier I was saying about the cost, but also readmission is one of those things that why it's important to kind of monitor and prevent. I really like this graph that we on a study where they kind of highlighted things to focus perioperatively, interoperatively. So we'll go through some of these areas and kind of highlight what we need to do. There's a lot of things to focus on surgical site infection, but we'll highlight some important points. Not all of them, but some of them that we think it's important. So evidence for standardized pre-admission showering regimen for adhesive maximal, so CHG bathing, 4% CHG bathing. So it's been kind of controversial. Some studies say yes, some studies say no. But recent SHEA guidelines also recommends you can do CHG bathing. So this study looked at 4% CHG bathing for our patient to see if that can reduce colonization and did that reduce infection. So next slide, please. And CHG bathing is endorsed by many of these organizations, so that's really important to know. It's endorsed by the International Organization for Including the HICAPAC, APIC, AORN, our Nursing Association for OR, Institution for Health Improvement, all which recommend bathing or cleansing with antiseptic agent prior to surgery. So some sites use CHG bathing for about 3 to 5 days prior to a surgical procedure. And also they do CHG bathing prior to the actual surgery time. So you can do it either with the washcloth with CHG, or you could do it with I think you could do it with CHG wipes. There's wipes also present. So either way, I think we're missing a slide, but it's okay. Either way, CHG bathing has shown to reduce that's antibiotic, sorry.
Oh, okay.
CHG bathing has shown to reduce infections on their skin. So I'm just curious on here, is there any of you that do CHG bathing routinely for your patients prior to pre-op? Is there any protocol that you all have done to do CHG bathing at home for 3 to 5 days prior to coming for an elective surgery? For hip, joints, cabbage, any type of surgery? I was just curious. You could type it in the chat if y'all are doing that. But definitely a lot of institutions have gone towards using CHG bathing to kind of reduce surgical site infections prior at home and also perioperatively. So that's one tool. Oh, we have a chat. Yes, we do. Thank you, Jennifer. Just curious, Jennifer, do you also do it at home or just pre-op in the hospital? You could type it in, but that will be good to know. But a lot of people are doing it, giving the patients to take home and do the CHG beading as well. Next tool would be, oh, Jennifer, yes, we do. Does anyone not do it at joint? Does anyone not do it for joint replacement? There are still some facilities that have not implemented, not anybody we know, but there are people that are still, and I really think CHG bathing can help either wipes or cloth for definitely for our patients.
So it says depends on the surgery. Mostly we have them shower on their own
Yep.
and then use the CHG wipes in pre-op.
Yep. That is mostly a lot of the folks that's what they're doing and has shown to be very effective. So it's a great tool. Second tool is think about is timing of perioperative antibiotic. This started with skip long time ago, but this has become evidence-based practice to give preoperative antibiotic. We know studies show that when you give preoperative antibiotic, it decreases surgical site infections. Do you ever see now, Dr. Horn, anybody not giving perioperative antibiotic?
No, I think people usually get pre-op antibiotics pretty well.
Yes.
And sometimes, even if they're on good antibiotics with good coverage, they'll get another antibiotic just to make sure they get it and everything, which probably is okay, I guess. But sometimes we'll get questions about if the patient has an allergy to an antibiotic, what would be the next best thing? And we can always help with that, but it seems like they get it pretty well, I think.
Yeah, I see it's pretty well, I would say implemented in most facilities, healthcare facilities. Now, this is a large study. What they ended up doing is they reviewed over 54,000 people to see when should you give antibiotic? What timing? 0 to 60 minutes, over 60 minutes. So what they found was more than 120 minutes prior to incision. Patients had 5 times higher rates of infection. So it's really important to give antibiotic within that 0 to 60 minutes of time. That will decrease surgical site infection. And there's lots of data on this. So it's really important to implement antimicrobial administration 0 to 60 minutes. You might now ask, so can I give antibiotic then? Can I just give antibiotic really quickly before I cut? So I have seen some practices where they were not able to give the antibiotics 0 to 6 because it's 0 to 60 minutes. For example, cefazolin, they were taking the 2 grams of cefazolin, they're pushing it as the patient is going into the OR.
0 minutes.
Yeah, and then they're cutting the skin. So when you cut the skin, cut time is so close to pushing the antibiotic, you do not have enough systemic absorption of antimicrobials to be effective to prevent surgical site infection. So this is a really good takeaway. Here's some data that shows if you did it early too fast versus 26 minutes, you actually saw a decrease in infection when it was around 30 minutes or so. So it's really important as part of our practice to evaluate in your OR that you're not pushing the antibiotic when it's allowed, for example, cefazolin, that it has enough time to get into the bloodstream and into your tissue. So ideally, your antimicrobial should be given between 30 to 60 minutes prior to surgery. So that is a really important takeaway, because sometimes what happens is when you're doing your checking of your gap analysis or looking at things, you're like, oh, antibiotic given pre-op. But you also have to check the timing of antibiotic and how fast they're giving it as well.
Yeah, I think of it like at the surgical site when they're cutting, you want antibiotics there in the blood where you're cutting because you're trying to prevent bacteria from getting into the blood at that location. So I think of it as like bleeding antibiotics.
Yeah.
But I don't know that other people think of it like that. But if you push it at one site and then you cut at another site just at the same time, then the bacteria, can get into the blood there when really you want good concentrations at the site, at the location of the surgery at the time you cut. So, but it can be difficult with, OR times and
Yeah.
getting places,
I-
getting approval to go do the surgery immediately.
But that's why it's really important to kind of pay attention. And can you start the antibiotic peri-op? Do you have enough time between 30 to 60 minutes? So those little delicate dance that we have to do is going to be really important to help the patient. Discontinuing antibiotic, this is our favorite.
Yeah.
So they say that do not continue antibiotic for a long period of time after starting perioperative prophylaxis. So this is on the SHEA updated guideline in 2022. And of course,
Now I have seen some locations that they'll give something like cefazolin and then they'll say for 15 doses or something, or for 48 hours, or they'll want to continue it. So you're saying not to do that.
Yeah, the current data shows updated SHEA unless they have a real infection. Do you know what I mean?
Mhm.
If this is an elective surgery that you're doing, data suggests, although some guidelines stopping antibiotic within 24 hours, you don't, there's no evidence that the antibiotic given after the incision closure contributes to reduce of surgical site infection. So you do not even need to continue post preoperative prophylaxis. More we do that, more we get resistance, C. diff, allergic reactions. So it's really important perioperative and stop therapy.
So it sounds like when they leave the OR, you stop the antibiotics.
Stop the antibiotic.
Yeah.
Caveat would be that, let's say you have an intra-abdominal infection and you just had surgery, then you can stop the antibiotic. But elective, simple surgeries should be stopped as you leave the OR. Clarification, given IV push. Ideally,
So the timing between pushing and cutting is what we're discussing.
Yeah.
So it's okay to push it, but if you do, then you want to have the first incision 30 minutes later.
Like,
is that
you want to give it some time?
Yeah.
Thank you, Crystal, for that question.
Yeah, no, that's a great question. A lot of places have that same question.
You could, if you are going to push, you got to give it time for it to get into the incision site. So don't do cut immediately after. I know Samaya is on this call. Samaya, do you have any comments about that?
Yeah, and sometimes they'll be doing the push right seconds before they're cutting. Yeah.
Go ahead, Samaya.
Sorry, Samaya.
Yeah, thank you. I was also going to say that for the 30 to 60 minute before, that doesn't mean like starting the infusion and then going to the OR. Like it needs to be completed. So started and completed prior to cut. But there are some times where you can push the cefazolin and like you all were saying, because of timing to OR and all of that. But yeah, we just want to make sure before tourniquet placement and all of that, that there is appropriate antibiotic levels prior to cut.
Thank you so much. And with that, for antibiotic, it's really important to know we're dosing the antibiotics appropriately. So usually, for example, cefazolin, it's 2 grams every 8 hours. So you give 2 grams as your dose for surgery. But if the patient is over 120 kilos, 3 grams is appropriate. So your dose, weight adjusting your dose. So you're dose adjusting for the weight. And some other examples we have given for Vanco and gentamicin. But it's really important, if you can, certain antimicrobials, you have to adjust for the weight. And that's important to make sure that you do that. And redosing prophylactic antimicrobials is important if you have excessive blood loss or if your procedure goes a long time. For example, if you're giving cefazolin and your procedure is more than 4 hours, you might have to redose in the OR. Samaya, any comments on the weight-based dosing and redosing in the OR? In your experience?
Yeah, so currently there's not data on how often you have to redose. So there's timing. So for cefazolin, if your surgery continues past 2 or 3 hours, you should redose. But then if the surgery is continuing to go on, there's not data on like how many times you need to redose. But there's also evidence on if there is time and excessive blood loss, like greater than 1.5 liters, the antibiotic should also be given again. And then, like you mentioned, for the cefazolin, starting with 3 grams if they're greater than 120 kilos. There's not sufficient data to say you must redose again for that same dose, or you can give 2 grams again. So either one at this point is appropriate for redose.
Well, thank you. Any other pearls, Samaya, for antimicrobials that you, and I know you do this a lot during surgery.
Yeah, I would say just like any other antimicrobial stewardship practice, maintaining the narrowest spectrum appropriate. So cefazolin, even in penicillin allergy, because of its side chain, is still appropriate. So we don't want to be using something like a carbapenem for most surgeries.
Oh, thank you. That's a really good point, because there were some practices where folks were using ertapenem for intra-abdominal surgery, and that is discouraged. We do not want to, like Sumaya was saying, broad spectrum therapies, because you're definitely going to cause a C. diff and ESBL. So it's going to be really important to use the narrowest spectrum possible when you can.
Yeah, I think some of those places, you know, I think they were thinking if they use a carbapenem, then they would reduce the likelihood of getting post-op surgeries. But
it ended up having the adverse.
Yeah, but that's not a good idea.
Yeah.
You know, because if you're only thinking of likelihood of, you know, a post-op surgical site infection versus all the other badness that can happen with giving broad antibiotics like that, especially to the whole community.
Yeah. And there are effective therapies that are just as good as carbapenem. So so next topic. So we've touched base about dosing, duration of dosing, weight-based dosing. Now we're going to change topic to skin prep. So guidelines for prevention of surgical site infection. So antiseptic skin preparation. So prepare the skin surgical site immediately before incision using first choice alcohol-based solution of chlorhexidine, unless contraindicated. So this is really important. If alcohol is contraindicated, alcohol-based solution is and then you could use providine iodine. But ideally, whenever possible, CHG chlorhexidine is the best antiseptic skin preparation to reduce skin infection. So whenever you can, and that's endorsed and in the SHE guidelines as well. Another important point in the SHE guidelines is when you do prepare, for example, so abdominal surgery, you're going to do chlorhexidine to prep the skin. But how do you reduce hysterectomy and C-section infection? Use of providine iodine or CHG-based vaginal preparation agents immediately before cesarean delivery reduces endometritis by 59%, even when there's possible greater benefits, even if the mom is laboring and vaginal delivery. So to reduce C-section, endometriosis, hysterectomy infection, there's data now to do vaginal preparation with either providine iodine or CHG aging vaginal preparation. Products should be chosen according to the manufacturer instructions. There was some controversy in the past. Can you use CHG in the vaginal area? There's some data that you could prepare it appropriately, use that. So it's really important, whatever you're using, that if you're going to go to C-section or even if active delivery mom, using vaginal cleansing is very important in preparing that. And there's moderate evidence to do this as well. And we're seeing a rise in C-section infection, and there's a trend now, poor moms, not only are they delivering a baby, but imagine having an infection right after. That's devastating. What's happening is they're also having elevated hemoglobin A1C. So it's really important to try to help our moms, prior to delivery with their diabetic control, as well as one of the other trend in C-section infection and such is that When moms are going home, they're not aware how to take care of the wound, C-section wound really well. You know, they have a brand new baby, they might have other kids at home, and they're touching that wound with, you know, not wash hands, because it's a large wound, C-section scar. So it's really important in your facilities, if you're having moms going home with after C-section, giving them instructions on how to take good care of that C-section scar, how to make sure you don't touch it without good hand hygiene, giving them good dressing options that they could put, because I've had some moms, they have put sanitary pads on their you know, C-section scar because they didn't use the right things and they get infection. So it's really important to help our moms do good post C-section care. I'm not sure if you all are seeing this, but this is going to be very important to help post C-section. And here's another on the SHEA guidelines as well. One of the other highlights is what kind of sutures are you using to close, which is kind of interesting. So we're doing good skin preparation, but now after surgery, how are you closing it, right? So one of the recommendation is that when using sutures, consider using antimicrobial triclone-coated suture to reduce surgical site infection. Consider using sutures rather than staples when you're closing C-sections. CDC suggests, so there's some support from WHO. They have shown 28% reduction in infection. However, CDC suggests that using triclosan-coated sutures should be considered for prevention of SSI, but they don't say any evidence, no evidence of harm. They're not supporting it, but they're saying no evidence of harm. This is actually from this paper, sorry, not from SHEA, but it's really important to know that this is also can be a tool in your toolbox if you need it. Lastly, you know, we all struggle with colorectal surgery infection. So they did a large study in this group, over 13,000 patients. And what they did was when you're closing, abdominal wound closures, they looked at having clean tray and gloves. So routine sterile gloves and instrument change as time of abdominal wound closure. So when you know, it used to be that when you're closing abdominal wounds, you just closed it with that with the same gloves that were dirty because you were just like going through the pus, going through the you know, stool, and then use the same gloves to close. Now the study shows it's actually better. Before you close the wound, you stop, you deglove, put you know, you put new gloves, gown, and then on a clean tray, you close the wound. This study, it was pretty funny, cheetah trial, showed that by using clean wound closure, they were able to show 13% reduction at 30 days after surgery. So a lot of institutions are now going towards doing clean closure, which is important concept and important for our patients. It can be sometimes expensive, but at the same time, if you get a surgical site infection, it's prolonged stay, mortality, morbidity. So it outweighs that. So this is a good practice to consider when you have a dirty surgery, abdominal surgery, and you should consider clean closure. Lastly, the most controversial subject, hair removal. A lot of I have to work very closely with our surgeons. So AORN and other data, including the SHEA guidelines, updated guidelines, support that if you don't have to remove hair, don't remove hair. But if you want to remove hair for a patient, it's really important to remove hair perioperatively, not in the OR. And when you remove hair, it's really not a good idea to shave, because when you shave, you get all these little scars.
Yeah, microabrasions.
Yeah. You might not see it. You will get infection. Only time they say it's okay to shave is for scrotal surgery, because you don't want to clip the scrotum. But it's really important if you're going to remove hair to do it perioperatively with the clipper. And if for some reason in the OR it must be done, because sometimes you didn't you start the surgery, there's some more hair, wet the hair, damp the hair, cut the hair, and you use a vacuum device to suction the hair so that the hair doesn't spread all over. When you cut hair in the OR, which is happening a lot of places, when they clip the hair disperses everywhere, hair has bacteria. Then during surgery, they come back and land in the surgical sterile field. Not only that, the hair stays in the OR. You're not doing terminal clean after each procedure. It's going to stay in the air and land in another person's sterile field for next surgery. So really, if you're clipping hair in the OR, please check your practice. It should not be happening. It should happen perioperatively. And make sure nobody is doing razor removing hair. And if you don't have to remove hair, that's perfect. And this is very controversial because timing and not having enough staff, but this is the right thing to do. AORN has it on their recommendation, showed us the SHEA guidelines in 2022 update. Next slide, please. I think
and we covered this.
Yeah.
And then as far as organisms go, one of the questions is, about management and treatment. So if you have, a surgical infection at a post-op surgical site, the question is, what antibiotics should I choose? And part of that is, what organisms you have at your location and your antibiogram, but also, you want to cover the most common things, and the most common things being Staph aureus, MSSA and MRSA. Staph epidermidis can cause infections, enterococcus, strep infections. These are the gram positives, and then gram negatives. There are a lot of different kind of gram negatives. E. coli, Klebsiella, Pseudomonas would be, the common ones. But, if you're going to choose antibiotics, you want to choose something that covers gram positives and gram negatives. And then sometimes we have an answer, if it's a deeper infection and there's pus coming out, if you're able to get a swab of that, that would be helpful. If it's like a cellulitis on superficial, then you may not have an answer, but usually the superficial cellulitis, that's going to be a strep or a staph. But just want to cover the most common things.
And here's some links, and when we send out the presentation, you all can look at that. It has the updated SHEA guidelines. I didn't go into every single detail. And also I shared Stanford antibiotic prophylaxis. I really like the way they had it for different surgery, what kind of antibiotic and dosing. And then AHRQ slides were for HAI was there as well. So these are some good resources for you all to use. And we have some time now. I'm going to stop. I know we all struggle with HAI and we want to do the best for our patients. We kind of touch base on the right antibiotic dosing, the timing of antibiotic, when to stop, using what kind of skin preparation, before surgery, doing CHG bathing, during surgery, doing a chlorhexidine prep. For moms who are laboring, doing vaginal prep with, either iodine, povidone iodine, or CHG. So those are some of the things that to consider, weight-based dosing for antibiotic. But the biggest takeaway is we all have the tool, but it's really important to have a multidisciplinary team in your healthcare facility, physician, nursing staff, OR staff, infection prevention experts, stewardship, so that you could review each cases and find the opportunity. Perioperative for surgical site infections is also important to get patients optimized, smoking, hemoglobin A1C, and such as well. So we're going to stop here and ask for any questions that you all might have. Any thoughts, any questions, anything that you all are struggling, because we all are struggling with the same things in different places, so happy to share.
All right, well, if you think of anything, you can always send us an email, and we'll see, how we can help.
Yeah, and then lastly, Sumaya, do you have any additional thoughts or comments?
No, I think you covered everything in details. Thank you for all of this.
Okay, thank you
All right,
very much.
thank you, everybody.
Appreciate it, everybody.